introduction. So first of all, good morning, afternoon or evening to everyone, wherever you may be in the world. My name is Di McIntyre, and I'm the Executive Director of iHEA and hosting the webinar today. So welcome to everyone to the webinar, High Costs in End-of-Life Care and Alternative Economic Perspectives, which is hosted by the iHEA Economics of Palliative and End-of-Life Special Interest Group. So just some housekeeping. Today's webinar will run for approximately 60 minutes, and we will be recording it. So we'll also upload the recording on our website afterwards. We will also upload the presentation slides on the website after the webinar. So please don't worry if you can't read all of the slides. They will be available online shortly after the webinar. So I just wanted to point out a couple of features. There's a chat box down at the bottom. You'll see a list of everyone's names, who's connected. There's a chat box at the bottom. If you have any technical issues during the webinar, please write them in the chat box, and I will try to assist troubleshoot your technical difficulties. What I've done is mute everyone who is online, and that's just to reduce background noise. What I'd also like to do is, if you've got your video on, except for Peter, who's the presenter, if I could ask you to switch off your video. The reason is that many people don't have great internet access, and if you have your video running, it takes up bandwidth and makes it more difficult for those with poor internet to actually hear. I also wanted to say that we will take questions and points of discussion at the end of Peter's presentation. If I could ask you again to write any questions that you have in the chat box so that we're ready to pose those questions to Peter at the end. And finally, from a housekeeping perspective, we'll be circulating a survey following the webinar, and we'd like to get your feedback. So please just take a couple of minutes about that survey after the webinar. Okay, now before handing over to Peter, what I'd like to do is just provide a little bit of background to the Economics Palliative and End-of-Life Special Interest Group. It was established earlier this year, and it's convened by Nikki McCaffrey from Deakin University and Peter May, who is presenting today's webinar and who you should be able to see in the video up in the right-hand corner. And the group was set up to try to grow economics capacity in this field. And this field is distinguished by widely recognized policy importance and low economics research and activity, unfortunately. So hopefully today's webinar serves as a good advert for the work that Special Interest Group can do. And just to mention that if you'd like to join the Special Interest Group, you can do that via the iHEA website. Finally, to introduce the presenter today, who is Peter May. He is a research fellow in health economics at Trinity College, Dublin in Ireland, and he specializes in palliative and in end-of-life care. He co-leads the Palliative Care Economics Research Group at Trinity, which is among the most active in this field worldwide. They collaborate widely on studies in Ireland, England, the rest of the EU, and the US, using multiple designs and methods, including randomized controlled trials, cohort studies, longitudinal surveys, and micro-simulation modeling. So I'm just going to hand over to Peter, and Peter, I have given you presenter rights, so you can just click on share screen in the middle. It should be in the middle of your screen. And then I will put myself on mute and we'll be ready.
So before you go on mute, Di, can you tell me, can you see the slides now? Is that working as we want?
Yes.
Okay, perfect. Thanks very much, Di, for that introduction. Before I start, a couple of quick caveats. The first is that this is, some of this is published work, some of this is ongoing. So I want to acknowledge multiple collaborators to get to this point, and in particular Brian Castle, Charles Norman and Sean Morrison. Their names are not on the slides because they haven't seen them, because it's ongoing work, so they get to share the credit but get none of the blame if there are errors to follow. For people who are not working in this field, there's a couple of abbreviations will recur, EOL for end of life and LYOL for last year of life. So by way of an introduction, it's hard to know without knowing the participants on the call how familiar people are with this, but we've known for about 25 years that dying is an expensive business. The Lovitz and Riley work showed that about a quarter of Medicare spending towards the end of the 20th century was accounted for by the 5% of beneficiaries who died in a given year. More recently, the proportion of Medicare beneficiaries who die is dropping, and the proportion of costs is dropping more quickly. So it's probably now about 40% of beneficiaries die, accounting for about 15% of costs as more people join the pool, living longer with multimorbidity. But despite those trends, the last year of life is emphatically the most expensive of our lives on average, as these data from the Kaiser Family Foundation would show us, about 4 times more expensive for a decedent than a survivor, unadjusted for illness burden. And this is at least a topic of curiosity for economists, because it feels kind of counterintuitive. We want to fund interventions optimally where marginal cost equals marginal utility and our willingness to pay at an individual or societal level, and it doesn't feel like these end-of-life year costs meet that kind of that measure, because on the one hand the costs are higher, and yet if anything you feel like the utility level might be lower because the people in question have very high illness burden. They might be less amenable to treatments, harder to shift the needle, as my American collaborators would say. And there's also a very, a much shorter payback period on the investment compared to something like a child vaccination or a hip replacement. And so this feels intuitively like a potentially scarce use of poor use of scarce resources. So about 10 to 15 years ago, some team of economists, superstar economists, it has to be said, Gary Becker and others, put together a theory that they thought explained why these high last year costs might be rational and reasonable. And there's a series of assumptions built into that, but it hinges on the fact that when we're facing death, priorities and preferences change. Wealth, beyond leaving wealth in your will, resources have no opportunity costs. You can't take it with you. Perhaps we value time slightly differently, and value improvements in that unique time-limited phase more highly. There's potentially distinct third-party effects given the unique experience of bereavement. Possibly hope even for treatments that aren't particularly efficacious raises their cost effectiveness, and other assumptions of this type. And the implications of all of that is that we systematically undervalue the utility of health improving interventions towards the end of life, and that's why spending is higher. And just recently, a discrete choice experiment in the Journal of Health Economics from researchers in Zurich demonstrated the Becker assumptions empirically. using the case of asking people the extent to which they'd be willing to pay out of their own pocket for a new, extremely expensive, so beyond the sort of societal cost effectiveness threshold that we conventionally think of, a new cancer drug that might extend their life. And this work is all extremely interesting. As an economist, I'm, I enjoy reading these papers, and I find them thought-provoking. It does feed into a specific subset of end-of-life economics around so-called quality problems. Jeff Round has a very good summary of that. And specific case of out-of-pocket costs and the phenomenon we see in America of particularly younger people who get cancer diagnoses, bankrupting themselves, trying to identify efficacious treatments. But when we think of that large picture Medicare perspective on the spiking costs at end of life, this whole framework really, I think, has very limited face validity. As an economist, I like it. As somebody who attends palliative and end-of-life care conferences, I have to tell you, you wouldn't get very far with this kind of framework for that kind of audience. One of the immediate problems is this idea of the reaper on the shoulder changing our decision-making framework has very weak empirical basis. We're extremely poor prognosis and knowing when people are entering an end-of-life phase, certainly over the last year of life. And that's been shown in both prospective studies of clinical decision-making, but also, there was a paper just a few weeks ago in Science that used large data sets retrospectively and machine learning, taking vast numbers of predictors of people who died and did not in Medicare. And it's that kind of prognosis, prospective prediction of who's entering an end-of-life phase is not really a thing. This idea that somehow we're evaluating and organising care on the basis of rational, objective evaluations is also somewhat flawed. There is, as the Jeff Round survey would tell you, there's very little actual quality analysis been done in this area, and one of the reasons for that is that we're very seldom talking about, in discrete treatments, novel cancer drugs that are going to extend life. Often we're talking about bundled care across multiple settings for people with complex needs, and those things are obviously quite resistant to conventional cost-effectiveness approaches. And a similar point, I suppose, with respect to this idea of the novel cancer drug is that is an observed empirical phenomenon, but it makes up a very small proportion of those high Medicare costs that we're seeing. Here are just some references that will be more familiar to a palliative care audience than an economics one on the observed empirical reality. So for one thing, patient preferences outside of younger people with aggressive cancer and poor prognosis, patient preferences are generally not for higher intensity of care. People who are older, have multiple chronic conditions, the preference tends to be for lower intensity of care. So there's no real basis to interpret high costs as reflecting patient preferences at the population level. Similarly, we see evidence that patients and their families have poor experience at end-of-life systems, are not good at managing that phase, and so there's no real prima facie reason to assume that high cost reflects a high utility yield. Studies show that physicians are not good at understanding patient preferences or even at trying to elicit them. And the Downey study is interesting for particularly showing that physicians are worse at getting patient preferences when the patient wants less care than when they want more. And so this idea of patients as informed, autonomous, rational agents is probably just not appropriate to the real world context. And as I already alluded to, when we look at what are the drivers of those high costs at a very high population level, it's actually the complex multi-morbid group of those that are driving the high costs rather than explosive responses such as novel, high-risk, high-cost, high-intensity therapies. And so, in light of all of this, I think that the willingness to pay interpretation is certainly thought-provoking and interesting for specific subsets of economics of end-of-life care of serious illness. But in understanding the high costs at the population level and population level experience is probably not a particularly powerful way to think about it, for all of these reasons that I've talked about. But patients are not rational or autonomous decision makers. The end-of-life phase prospectively doesn't really exist on a wide scale. The last year of life costs are not generally novel, aggressive, life-saving treatments or life-extending treatments. They're bundles of ongoing management of care for people with complex needs. And so when we're thinking about this in our palliative care research group here and with some of our international collaborators who Di mentioned, I think about this less in terms of patient decision making and instead about decision making on the supply side. We are still, as an economist, I still think it is ultimately we're interested in the decision science, but under-examined is the decisions being made both by individual, at the sort of individual clinician or team level, and also at the wider system level of how people with terminal illnesses are accessing and receiving care. Fundamentally, I think that this is going to come back to this at the end, but this is more a question of we have healthcare systems designed to provide acute episodic care, and we have populations who are aged, multi-morbid, with complex ongoing needs, and end-of-life care is in some sense a subset of the multi-morbidity problem rather than some kind of distinct fantastical phase. So how do we start to think about illustrating this idea of decision making on the supply side using data? Well, we want to think about, are there interventions or ways that we can observe improved decision support in the treatment of seriously ill people, and if this decision support is affecting costs, and in particular, is it affecting the high-cost subgroups who we know are driving those high Medicare expenditures? And so, in this study, this is where we use the intervention of palliative care. So, again, I don't know what the base level of palliative care knowledge is on this call, but very briefly, it is an interdisciplinary specialism originating in care of the dying and alleviating pain and maximising quality of life right at the very end of life phase, but increasingly over the last 25 years is recognised as having benefits across the trajectory of serious disease. The World Health Organization definition is referenced there. The American Society of Clinical Oncology now recommends palliative care concurrently with curative treatment from the point of diagnosis for all metastatic cancer. And one of the reasons why it does that is that palliative care is consistently associated with improved outcomes for patients and carers, better pain and symptom management, in some randomized controlled trials, longer survival, in others, no difference in survival, but never shortened life expectancy. Also some care improvements, better quality of life, lower depression, stress, things like that. And particularly here, we're going to use hospital palliative care data. So in the US, where the dominant model of provision is a consultation team led by a specialist physician with specialist nurse support, and then psychosocial support as well, social workers, chaplains, etc. And the team becomes involved in the treatment of seriously ill inpatients at the invitation of the primary attending physician. They advise on pain and symptom management, initiate goal of care discussions, and transition planning where the patient will go next. And in that sense, we're conceptualizing the intervention for the purpose of trying to understand the end-of-life care cost phenomenon as in improving decision support, improving decision-making through decision support on the supply side. So particularly, you're going to think about two groups who are known to be associated with high costs and poor experience in that phase. Firstly, those with multimorbidity, two or more serious chronic conditions coexisting. You know that group is particularly poorly served by these sorts of aged health systems, and they therefore experience more admissions, higher costs, and poor outcomes. Secondly, we're going to take a look at differences by ethnicity. There's a phenomenon in the US where our data come from that, in particular African Americans and Hispanic groups are underserved by the healthcare system for most of their lives, and then in end-of-life care they have higher costs, more intense utilization than non-Hispanic whites and the population average. And some of those trends at end of life may represent genuine cultural differences, informed preferences, but there's also fairly good evidence that they also reflect the earlier underservedness and relative lack of integration into continuity of care earlier. So from that we'll generate 2 research questions to examine treatment effect heterogeneity. Does palliative care have more of an effect on hospital costs and other use if you segment your groups by comorbidity status, and does it do so if you segment them by ethnic group? The data here are taken from multiple previous retrospective studies of hospital palliative care in the US and one smaller prospective study, overall about well over 95% of the data. And to be eligible for the study, you have to have been admitted to one of our participating hospitals with one of these 7 life-limiting conditions. And then we're going to look at what are your outcomes in terms of the costs during that admission at which you're enrolled, and then where we have the data, what are your hospital costs following discharge. And we'll compare outcomes for those who receive palliative care during the admission and those who do not. Already covered that. So they're retrospective, almost exclusively retrospective cohort studies. For more detail on where the inpatient analysis you can follow May at the end. The discharge data come from a slightly different source, so you have to email me to know the details, but it's all essentially routinely collected data of people with terminal illnesses being admitted to the hospital. And the way we do these analyses is hypothesis driven, so we formulate these research questions and hypotheses. We segment our sample according to the dimension of heterogeneity that we're interested in, and within each subsample then we balance those who received palliative care with those who did not using propensity scores. We estimate treatment effects in a fairly sort of straightforward way fitting a nonlinear model and bootstrapping the standard errors. And then for a given sample, for example, those with 2 comorbidities and those with 3 comorbidities, we can estimate a treatment effects on palliative care for each group, and then that treatment effect is normally distributed. So then we can compare the 2 distributions using t-tests or one way and over to see whether any observed differences are actually statistically significant. Very briefly, the summary outcome data, which are weighted according to the observed confounders that we have. You see the same trends if they were unweighted. So as you would expect, the mean cost of hospital admission increases the higher number of comorbidities you have. The Elix-Hauser index is an additive index. Comorbidity, where you get 1 if you have a condition, 0 if you don't, for 31 different things, and they're added up. So, and the rough distribution here is pretty much the groups are split equally across those four groups. So there's about 25,000 or 30,000 in each of the groups, with increasing costs during their index admission. Also increasing costs after discharge, although or increasing numbers of nights in hospital after discharge, although that increase is less dramatic. We don't have the cost of admission index admission data by ethnicity today, but I do have the post-discharge utilisation. And you can see that again, as we would have expected from the data, that accounting for diagnosis, illness burden, age, and socioeconomic status as denoted by insurance status, the African American participants spend more time in hospital after their initial discharge than do the non-Hispanic whites. As a note says there at the bottom, we're not only interested in these two groups, but these are the two groups for whom we have a sample size to perform the analyses in these data. So here are the results by multimorbidity for index admission, the cost of the initial hospitalization. These were published earlier this year in JAMA Internal Medicine, and references there. And graphing estimated cost saving on the y-axis and number of comorbidities subsample on the x, you can see that there is a consistent pattern from left to right, that the higher number of comorbidities in the subsample, the larger is the cost saving effect. And when we do the ANOVA test, it's that they are significant. The 3+ group have significantly larger treatment effects than those with 0 or 1. These are the post-discharge data. I need to work out a better way to present these because they're on slightly different scales. You can see that there is a big reduction relatively in number of days spent in hospital post-discharge for those with higher numbers of comorbidities. That difference is not there for the 0-1 group. There is also a gentle downward slope for numbers of readmissions and time spent in the ICU, but those numbers are low to begin with, and I'm not anticipating that those associations will be significant. Here are the results by ethnic group. So first of all, looking at the total number of days or nights spent in hospital after index discharge, you can see that palliative care significantly reduces time spent in hospital post-discharge for both African Americans and for non-Hispanic whites. And then if you compare that, the estimated treatment effect of -5.8 for African Americans, -3.1 for non-Hispanic whites, the t-test is on the far side of the table, tells us that that difference is itself statistically significant. So palliative care has more of an impact in reducing readmissions among African Americans than among non-Hispanic whites, having started from a point where the African Americans had higher levels of utilization in that category. Equivalently in ICU, palliative care is reducing time spent in the ICU, which we would expect, but the difference between two ethnic groups is not significant, and total readmissions, palliative care is reducing readmissions and doing so statistically significantly more so for African Americans than for non-Hispanic whites. So, taking this large cohort of hospitalized adults with one of 7 terminal illnesses over a 15-year period, we're seeing that palliative care consistently is associated with lower cost of admission and reduced costs following your reduced utilization discharge. More importantly, we're seeing patterns of heterogeneity within that, whereby the treatment effects are largest for those who have highest levels of use, and where we know from prior literature that high use is generally associated with poor outcomes and inappropriate care. When you do analyses like this, there are a lot of sensitivity analyses behind it. Perhaps most importantly, what people ask about a lot is palliative care utilization lower due to high mortality rate? And the answer is no. That effect holds even if you do a competing risks analysis where you treat dying as a competing risk. We also check these things against with and without propensity scores using alternative nonlinear models or just log transformed utilization outcomes, and the key conclusions all hold. So to come back to where we started, I think that the economic literature on high end of life costs to date has tended to focus on the patient and a kind of microeconomic view of the world of rational, well-informed decision makers choosing to pursue these paths. This has poor space validity in the context of what we know from the clinical and health services research and of life care. And instead, I think I'm more interested in thinking about supply-side decision-making or shared decision-making where patient preferences and patients as active decision-makers within the process will impact things. And rather than thinking of high costs as reflecting preferences and high utility, instead, in a lot of cases, they're a marker of poor, inappropriate care. And we can see that when we segment samples of seriously ill people according to baseline factors that are associated with high intensity inappropriate care, we can see that palliative care, improved decision support, is more impactful for those poorly served groups. Fair number of limitations, of course, which you have to acknowledge. So at the basic level, these are not trial data, but retrospective cohort data. A number of known unknowns that which we could control for, most notably patient and physician preferences. We only have hospital costs, not costs elsewhere in the system. So if, for example, palliative care is discharging people from hospital to a nursing home, then the cost savings we're seeing here are misleading. However, that isn't really what we would understand from the evidence. We would think that it would result in spending more time at home. There is a concern about cost shifting to informal carers in particular, but I think that hospital costs are a legitimate source of inquiry in their own right. They account for over 50% of those costs in the last year of life. And so even though as economists we always want the comprehensive societal viewpoint, if we're talking about more than 50% of Medicare expenditure, then $1 billion here, $1 billion there, pretty much we're talking about real money. There is a slight sleight of hand here in that I am not presenting data of people's last year of life. I'm presenting their data from when they're admitted to hospital with terminal illness. And I'm doing that not really due to data constraints, but rather sort of, that is an autonomous decision, rational decision of mine, because I think that deceiving cohort studies where we count back from death introduce other increased biases into analyses. The Peter Back article is the touchstone here. And if I did sensitivity analyses where I only included those who had died and counted back, the magnitude of treatment effects that I presented here would just be much larger. And I think that's because of the bias that we introduce when we assume that that people who didn't receive palliative care were just as good or as well-known candidates to receive it at the time. One thing I haven't done here is delineate sort of the competing dynamics of multimorbidity and race. As we would have expected, we do see slightly higher Elix-Hauser scores among the African Americans than the non-Hispanic whites in these data, but the magnitude is quite small, and I think probably the next stage for this is finite mixture model or something, some kind of latent class analysis where we pick them apart at the same time. I'd be very surprised if just simply higher illness burden among African Americans was driving the results of this. Yeah. I think more importantly, it is critical to acknowledge that this is one oversimplified, in some senses, look at the racial differences that we see consistently in America. Using the data that I have, I wanted to move beyond the multimorbidity one. It's a question of how we manage complexity, whereas the racial differences one is different, is about something to do with engagement with patients, patient preferences, elicitation of those preferences, and so on. But satisfactorily answering those questions and the appropriateness of palliative care consistent with preferences for different ethnic groups is clearly well beyond the scope of this work. And finally, this is not intended as a, exclusively sort of a palliative care inquiry. I think palliative care is one good example, but you do see others in the literature of ways to think about improving decision making in the complex management of complex cases. So briefly then, very briefly to finish, I think this graph is always important. This is long-run mortality by year of birth, or to put it another way, we're all going to die. Less facetiously, I can illustrate the point with data from Ireland, that we think that the number of people dying in absolute terms who have palliative care need will nearly double over the next 30 years. And that is because we do have a young population by the standards of a high-income country, but we have population aging, so people are going to live longer, and more of them are going to have palliative care needs than previously. So there's those two dynamics at once. If you did the same thing in England, you'd probably find about a 50% increase. It's not as dramatic. But then if you think of low and middle-income countries, the gradient of that slope will be really quite, extraordinarily steep over the coming century. The shift from infectious to chronic disease is obviously already happening there, and in a context where the capacity of systems to manage and cope with those kind of problems is clearly far, far lower because due to both resource and experience issues. So my concluding thought, therefore, is that end-of-life care is, in some sense, the ultimate universal healthcare issue. It always amazes me. Journal reviewers tell me that end-of-life care is, not particularly important or relevant to everybody, given that long-run 100% mortality rate. I think that there is a really serious but well-recognised policy importance on getting a grip on the management of people with multiple serious chronic diseases, with multiple terminal illnesses, and yet the level of economics work done in this area is relatively low. The amount of work done in low and middle income countries is next to zero. So I want to use, I suppose, this platform to encourage people to give a little bit of consideration to these issues, to think about end-of-life care as not some unusual, distinct, fantastical situation where people are rolling the dice in the face of imminent demise, and instead thinking about this as part of that bigger question of how we conduct good economic studies that improve the management of complex, multi-morbid cases on an ongoing basis. There's many other, this is the cost side is my main area of interest, but there's many other fascinating questions in this area, including the quality problem, the management of time, and how people's preferences may or may not change in end-of-life phases, which some of my colleagues are interested in. And so hopefully, well, we'd certainly be delighted if a few people who are listening in today were to join the group and join the effort to improve economic studies in this area. Thanks.
Great, thank you very much, Peter. That was an excellent overview, both of some of the issues more generally in terms of palliative and end-of-life care, as well as really very interesting results from the study in US data. There haven't been any questions posed in the chat box. So what I want to suggest is that if anyone would like to ask questions, you will see on your screen right over on the right-hand side, next to your name, you'll see a little microphone which will be red. You can unmute there. Okay, so there are some questions coming through now, but you can also unmute your mic if you would like to ask directly. Peter, the first question that I've got here, what database has been used for this study?
So it's not a sort of publicly available or publicly compiled database. It is the full details are in the JAMA internal medicine reference that are in the slides. But what we did was we did a systematic review of all prior hospital studies of palliative care in the US, approached the authors to get their data, pulled the data together. So it's 131,000 inpatient admissions over 6 previous studies of inpatient hospital palliative care in America.
Great, thanks. Peter, there's some questions from Eric Finkelstein. First of all, he says, great talk. Thoughts on how you might do that analysis using instrumental variables in addition to propensity scoring? Not sure what a valid instrument would be, but may be possible. Any thoughts?
Yeah, so that's definitely that's something that we're aware of. There's of the 6 studies that I'm talking about that we pulled, one of those used an instrumental variable, and it's a study from VA hospital. So the instrument was the attending physician and specific, I can't remember, but some quantification of that attending physician's age, prior palliative care referral behaviours, trying to capture whether the primary attending doctor was more or less likely to involve palliative care in their care ex ante. But that only works in a VA study because you don't get to choose your doctor in a VA hospital, whereas in all of the other studies, people are choosing their own doctor, so the instrument is no longer valid. One of the 6 is a primary research study that did collect a lot of data points, and I was one of the people who spent time trying to find a valid instrumental variable in a much richer set of demographic, socioeconomic process variables, and we didn't find one. So, I mean, I agree that, that an instrumental variable would be a better approach, but it is definitely a challenge in these data. Possibly if you had a kind of these studies are taking the data that's available, maybe if we got some kind of comprehensive recruitment that could be instruments in regional factors of, how health systems and physicians behave, I don't know, but it's something we're thinking about and haven't really been able to crack. So if anybody can think of a good instrumental variable, then please email me as a matter of urgency.
Great. Peter, I wonder if you want to just scroll down to your references. The one question is, can you repeat the reference explaining retrospective end-of-life studies are less useful than prospective?
Sure. So I'm sorry, I've lost track now of whose screen we can see. Are you looking?
No, we're still seeing your screen. We're still seeing your screen. I've left you with the control.
So how do I? There we are. So
just page down.
There is, so the very first reference alphabetically there is Peter Back and others from JAMA in 2004. So that makes the point about the bias issue, that if you take a group of people who have died, then that has certain advantages. You've got more population representativeness than if you are enrolling people prospectively. But to then look back and see what treatments they did and didn't get, and comparing their outcomes, is implicitly assuming that their relative trajectories to death are equally well known in both cases. So if the palliative care patient whose utilisation in the last 6 months and the usual care patient in the last 6 months were equally known to have, or equally thought to be equally likely to die within that 6-month period, and that is a recipe for bias, as the back paper illustrates. It caused quite a lot of controversy at the time, and I think still kind of does. So then you can find responses by Joan Tino and Craig, what's his name, Earl, and in JCO and Dejama's letters page and various other places. So it is an ongoing thing. I'm not saying that decedent cohort studies are not useful to answer any questions, but I am skeptical about their value in understanding economic effects of treatment choices. I also referenced a paper verbally that is not in the list, and that is the leader report, and that is INAV, EINAV, and that was in Science over the summer, June, July time, and that was using big machine learning and big data sets to try to see what are the ways that we might be able to identify those people who are going to die versus not. And they essentially find that even the supercomputers can't. So that's worth looking at as well, in kind of reiterating the point that there is a problem with counting back from death because it implicitly assumes a prospective prognosticability that neither us nor computers have.
Great. We're getting questions streaming in now. Okay, so one of the questions is your discussion seems not distinguish between settings where patients and payers are one and the same. So in Singapore, where this person lives, patients tend to also be payers, as there is NHS equivalent. Would your conclusion change for a place like Singapore or a third world country where patients truly pay their way?
That's probably be better answered by somebody who's more steeped in the details of cost effectiveness analysis than me. But I would say that probably my instinct is to say not really, because our willingness to pay and the use of scarce resources, in some sense, it doesn't matter who is paying. We still want those resources to be used in the optimal way. The question of the out-of-pocket costs, I think, is really is a way of trying to get at whether perhaps people who are in a phase of terminal illness place a higher value on these treatments than perhaps we realise in society at large, and therefore we're underestimating our societal willingness to pay for high-cost drugs. But the essential question of who pays, I don't feel like it undermines the fundamental point of this is a question of supply-side decision-making as much as demand. Now, if in Singapore, because people are co-paying for their own care, they, as a direct consequence of that, or as a part of medical culture, they do have better informed, more direct say in their treatment choices than happens in the US system, then that obviously is a much more important difference with much bigger implications. But I mean, if you take then the example of low middle income countries where there's obviously much higher out-of-pocket spending, I think it doesn't change the principal point that wise decision making may actually reduce costs rather than increase them, whoever's paying.
Great. Peter, I'm going to pose two more questions and then we'll wrap it up. Can you maybe just shift on to the last slide so that people can see the other references? So one of a question here from Ashley August. What impact do advanced care plans have in end-of-life care? Is there any literature addressing this?
There definitely is significant literature addressing this. The findings are very, very mixed. I think initially people were optimistic, confident that this could mitigate a lot of the phenomena that I've been talking about today of inappropriate high-intensity care near end of life, but I think that more recently studies have shown fairly mixed results in their effectiveness. So it's not my direct area. We do have advanced care plans in the one prospective study here, so I could go back and look at that and see if advanced care plans also has some kind of mitigating effect. But I think I would say to the questioner really that the starting point would be a literature search. I'd be extremely surprised if there isn't a systematic review of the effects of advanced directives in the last 5 years. And that will have found, I think, mixed findings with specific reference to what I presented today. The important thing about advanced directives is there's a really important known unknown around the racial differences that we see, because the African American population has lower uptake of early advanced care planning than the non-Hispanic whites, and to what extent that is a well-informed choice, and to what extent it is a lack of good integration into the healthcare system when it's needed, is a kind of open question that we need to answer better.
And a final question, there were two that were similar, is could you reflect on what other factors besides informed preferences might account for some of the differences you found in ethnicity? And there was a related question, what do you think are the potential or probable causes of differences between white and black Americans?
Yeah, I mean, that is an extremely complex question, of which this, I think, this is our first look at this, and I think it's potentially a first step on a long road. So, I mean, there's a question of if we go back to the multimorbidity analysis first for a second, there is a question of, well, is the improved decision making to some extent, could you call it preventative, that it's essentially complex case management? So, for example, it's reducing adverse drug reactions. The more comorbidities you have, the more things you have, the more doctors around the bed, the more likely that the treatment regimens are going to clash, and palliative care is good at managing that kind of thing. But there's also the question, there's the question then of preferences, of understanding what people really want. And then there is the question more of just even of listening to people, communicating with people to link them into other parts of the healthcare system. So one of the other parts of this program of work has shown is that where previously it was thought that palliative care was just reducing intensity of care, so people were getting less chemo than they were before, we're also showing big differences in hospital length of stay. So we're thinking, obviously, that might be partly because people are staying in for less chemo, but also the different components that it's probably goals of care discussions and discharge planning is playing an important role as well in getting a better understanding for doctors that patients don't want to be in hospital getting these treatments and undergoing these tests unless there's a clear value for them. And so I think there's probably all of those things that we've hypothesized and found in more detail in the comorbidity analyses. I think you would also expect to find the deeper we dig into the racial differences. So there will be definite there will be legitimate differences in the sense of well-informed preferences. People just want different things. But then there is potentially an issue of, are patients being treated differently by healthcare systems, and getting their preferences heard or understood is not so straightforward, with lower health literacy and so on. And then there is the question of that perspective of, if you're linking people into the into discharge plans, goals of care plans, that perhaps just people who previously would not have had a good discharge plan and therefore been primed for another readmission are instead just on a better treatment pathway, whereby when they leave hospital, they have ideas of where the additional supports are that will stop them coming back again.
Great, thank you. That is perfectly timed. Before signing off, I just mention that if you look in the chat box, Eric Finkelstein kindly shared the reference that Peter made to the article in Science. And yeah, all that is left to do is to thank everyone for joining this webinar, and to particularly Peter May for really a very interesting presentation. And I also hope that it has generated more interest in the whole area of end of life and palliative care economics. Please, those who participated in this webinar, if you could mention to others how brilliant this webinar was, and that you're going to post the recording on the iHEA website, so people who weren't able to make it for today's webinar live can view it. And encourage people to think about joining the special interest group. So thank you very much to everyone. We're going to end off now, and we hope that